you.
So, about notification, all the positive cases will be reported to Ministry of Health, but without name, without address of the people living with HIV. Only sex or age or the area, like what kind of district, Central Jakarta or something like that, for the statistical purpose, but not mention who and where and who other. So notification is only for statistical epidemiological purpose. About tracing, we encourage, like we have a husband who is positive, we encourage also the contact to be tested, but it at the voluntary basis, not mandatory basis.
Okay, we will conclude the sessions now. We will have a break for 5 to 10 minutes to prepare for the panel discussions. Thank you all sides to join us this morning. We will come back after 5-10 minutes. Thank you.
Thank you.
Sorry, Professor Fahir. This
yes.
is from Timor-Leste. Before going to have the break, I would like to suggest that maybe the microphones from your side, maybe they are not functioning properly, because we missed some of the messages from Professor Sam so far. Thank you. Maybe your technician has to look after it. Something to do to improve it. Thank you.
Okay, thank you very much. I will see you in 5-10 minutes. Okay. Panel discussions. We have 4 countries that will present the country situation and country response to HIV/AIDS problem. We will start with the Philippines, then Timor-Leste, Malaysia, and Indonesia. Each of the speakers will have 15 minutes to present the country situation and response. Then we'll move to the next country until we finish 4 speakers. Then we'll start with question and answers. I will start with short introductions for the 4 speakers before we start with the Philippines. From the Philippines, we have Dr. Fercito Avellino. Dr. Avellino is currently the Executive Director of the Philippines National AIDS Council. He had training on field epidemiology under the Joint Training Program of the Philippine Department of Health and the CDC Atlanta. Dr. Avellino holds several posts at the Department of Health before his appointment at the AIDS Councils. The next speaker is Dr. Mario Agustin. Dr. Mario Agustin currently is a senior HIV advisor, part of the UN AIDS Security and Humanitarian Response in Timor-Leste, and this is again part of the United Nations Integrated Mission for Timor-Leste. Dr. Agustin is a physician who have extensive experience in the HIV/AIDS field, in the Caribbean region, and in Africa. Our next speaker is from Malaysia. Dr. Karina Razali is currently a freelance and independent consultant for HIV/AIDS. She holds PhD in mathematical modeling of HIV and hepatitis C epidemic in the Asia-Pacific regions. She taught epidemiology and biostatistics at the Department of Social and Preventive Medicine at the University of Malaysia between 2000 and 2004. And she is also the research support advisor at the Center of Excellence for Research in AIDS at the University of Malaysia. Last but not least, our speaker from Indonesia is Professor Samsurijal Zauli. I would like to introduce him again for the second time. Prof. Samsurijal is a professor of internal medicine at the School of Medicine, University of Indonesia. He holds a PhD in medicine from the University of Indonesia, and a honorary fellow, American College of Medicine. He is member of the Working Group on AIDS, University of Indonesia, and again, one of the pioneers in HIV/AIDS research and treatment in the country. Now I would like to invite Dr. Avelino from the Philippines to present his country situation and response. Please,
Thank you.
Dr. Avelino.
Thank you and good morning. I will be presenting the Philippine experience on HIV. My presentation will cover two major parts. Part 1 will present the HIV epidemic or epidemiology in the country, while Part 2 will present how we as a country respond to the health and societal threat of HIV. Can I have the next slide? Yes. The Philippines remains a low prevalence country with reported HIV infection at less than 1.01% of the population. In 2007, the Philippine Department of Health and the World Health Organization estimated that there were 7,490 people living with HIV in the country, up from 6,000 estimates in 2002. Can have the next slide, please. Figures from the AIDS registry of the Philippine Department of Health reported 66 HIV seropositive individuals for the month of April this year. This was 40% increase compared to the same period last year, which is 47. This figure brings the cumulative HIV positive, which is from January 1984 to April 2009, to 3,826 HIV positive. 3,016 or 79% were asymptomatic and 21% were AIDS cases. The age group of cases showed that 22% belong to the 25 to 29 years age group, 20% belong to the 30 to 34 years, 17% for 35 to 39 years. 71% or 2,702 of cases reported were males. Sexual contact was the leading mode of transmission. Next slide, please. While the prevalence rate is low, trend in the last 3 years shows an increase in new infections. In the past year, an average of less than 20 new cases was reported monthly. But in 2008, the average rose to 44 new cases a month, and in 2009, 60 cases or above are noted to be reported monthly. Next slide, please. Having presented the short statistics on the HIV epidemic in the country, the Philippine HIV scenario shows the following facts. A steady increase of cases in the past 3 years has been noted. 34% of all new cases were reported only in the last 3 years. Mode of transmission is sexual contact. Heterosexual was noted in the early part of the epidemic. However, a shifting to male having sex with males, or MSM, had been noted in the last years. And lastly, other groups with increasing risk for HIV had been observed amongst migrant workers and injecting drug users. Next slide, please. This slide shows the demographics of reported HIV cases from 1984 to March of this year. Next slide, please. This slide also provides the basic facts of the Philippine HIV epidemic. Can I have the next slide, please? The increasing number of HIV cases has been attributed to the following red flags identified in the country that seems to be fanning the epidemic. Analysis of our integrated HIV behavioral serologic surveillance data reveals that the following findings: less adequate knowledge on HIV and AIDS, female sex workers with only 2%, male having sex with males with 10%, injecting drug users at 26%, and clients of sex workers at 9%. Another red flag is the result of 2008 UNGAS report, which shows that among PIP, the condom use rate is only 19%, while for MSM it's only 32%. And also, we have high prevalence of sexually transmitted infection. While the incidence of injecting behavior is thought to be low, the IHBSS report indicates almost half, or 48%, of our IDU reported using sterile injecting equipment the last time they injected. It must be noted that the virus is known to spread at a faster rate amongst IDU. In 2007, it was estimated that there were about 10,000 to 20,000 IDU in the entire country. The proportion of female IDU is estimated at 10 to 15% and presents a key population at higher risk due to engagement in sex work of many female IDUs. Next slide, please. PLHIV, or persons living with HIV, are often confronted with stigma and discrimination, especially in accessing health services, education, employment, and other social services. Based on the recent assessment of our AIDS Medium-Term Plan 4, only 18 out of the 48 localities identified as highly vulnerable, including the national capital, Metro Manila, were reached with preventive measures, while 10 of them received comprehensive essential prevention measures. The challenge we face now is how we can strengthen the response at the decentralized system, where local government units are given the vital role in pursuing long-term sustainability of response on STI and HIV. High HIV vulnerabilities related to unsafe migration and mobility call for concerted responses in responding the entire spectrum of migration from pre-departure to post-arrival phase. Next slide, please. The following or succeeding slides I will be presenting will show or present how the country responds to this health threat. The country's response to HIV and AIDS is based on the Philippine AIDS Prevention and Control Act of 1998, or RA 8504, which was enacted on February 13, 1998, and its implementing rules and regulations promulgated in April 13, 1999. The law promulgates policies and prescribes measures for the prevention and control of AIDS in the country. It institutes a nationwide HIV and AIDS information and education program, establishes a comprehensive HIV and AIDS monitoring system, and strengthens the Philippine National AIDS Council. Next slide, please. The national response is presented in the law in its 8th article. In this slide, we have the 8 articles. Article 1 is on education and information. Article 2 is on safe practices and procedures. 3, testing and screening as well as counseling. 4, health and support services. 5 is on monitoring. 6, confidentiality issue. 7, discriminatory acts and policy. And last, number 8, is on the Philippine National AIDS Council. Next slide, please. Considerable initiatives had been put in place since our first Filipino HIV positive case was reported in 1984 until the present. In 1992, the country was among the first in the region to set up one national coordinating body that focused on policy making to address HIV and AIDS situation in the country. The Philippine National AIDS Council, or what we call PNAC, was established through Executive Order Number 39, a central advisory body to the President and the Legislative. PNAC is a multi-sectoral council chaired by the Secretary of Health, with members presenting 17 key government agencies, 6 civil society from sectors affected by the epidemic, and 2 from people living with HIV. The day-to-day affairs of the Council is being coordinated by the Secretariat with staff from the Philippine Department of Health. Next slide, please. The national response to AIDS epidemic in the country is embodied in the AIDS Medium-Term Plan 4, or AMTP4. This strategic plan was conceptualized and prepared through a robust and wide consultative process, which was inclusive of civil society, different agencies of the government, multilateral, bilateral agencies, as well as corporates. The AMTP4 is the national blueprint of the national response to AIDS. It assists the country in the formulation of policies and prescribed measures to combat further spread of the virus. It likewise sets the environment to institute a national or a nationwide HIV and AIDS information and education program, establishes a comprehensive HIV and AIDS monitoring system, and strengthens the National AIDS Council. The Philippine National AIDS Council is responsible for overseeing the program implementation of this country plan. To operationalize this strategic plan, a national response to AIDS epidemic of the country is embodied in its operational plan 2007 to 2008. In 2008, the Council conducted a midterm assessment of its AIDS Medium-Term Plan 4, and results of this review informed the operational plan for 2009 to 2010, and subsequently the final assessment to be conducted in the early part of 2011. Next slide, please. AMTP4 will run from 2005 to 2010 with an aim of preventing further spread of HIV infection and reduce the impact of AIDS on individuals, families, and communities. It has 4 objectives as shown in this slide with corresponding strategies. Next slide, please. The succeeding slide, I will be presenting the different initiatives the country has taken on and systems put in place since the first case of HIV was reported. In 1998, National AIDS and STD Prevention and Control Program and AIDS Registry was established. From 1988 to 1993, the first AIDS Medium-Term Plan, or first AMTP, was developed. In 1994, the first organization of people living with HIV was organized in the country. It was also during this period that the country established the AIDS Surveillance Education Project in 10 sites. Next slide, please. In 1995, Bahay Lingap, a halfway home for asymptomatic Filipino living with HIV and AIDS, was inaugurated. In 1998, marked significant events in the country's response to the virus. This is the year during which the AIDS law was enacted. Next slide, please. It was between 1995 to 2000 that important policies were formulated. The HIV and AIDS workplace policy was formulated by the Department of Labor and Employment. The Philippine Information Agency developed the STI and AIDS mass media campaign and a manual for media practitioners. Issuance of memorandum order and development of modules integrating AIDS in the school curricula, including non-formal education, was released by the Department of Education and the Technical Education and Skill Development Authority, respectively. Memorandum circular was also released by the Department of Interior and Local Government, which directs local government executives to implement HIV and AIDS education and community-based services. This subsequently paved the way for the formulation or creation of local AIDS council and an enactment of local AIDS legislation in some cities and municipalities in the country. To date, there are 32 local AIDS councils established. Next slide, please. From 2000 to 2004, we institutionalized the LGU, or the Local Government Unit, and non-government organization partnership in several cities. The local AIDS council were established and local AIDS ordinances, including provision of budgetary allocation for HIV and AIDS activities, were enacted. In 2001 to 2004, the country was a signatory to the UNGAS Declaration of Commitment on HIV and AIDS and adopted the UNAIDS 3-1s. The 3-1s adopt the Common Action Work Plan, which is the AIDS Medium-Term Plan, a national coordinating body, which is the Philippine National AIDS Council, and the establishment of a country monitoring and evaluation plan. Next slide, please. In 2007 to the present, we piloted the implementation of prevention of mother-to-child transmission guidelines. To strengthen local response, we established the Regional AIDS Assistance Team, or RAAS, which was composed or is composed of 3 national agencies: the Department of Health, the Department of Social Work and Development, the Department of Interior and Local Government, to assist local government units in their local response. In 2008, we also initiated the midterm assessment, which resulted to the review of our plan. For this year, we are finishing our report to the President of the Philippines. PNOC-UNDP Joint Program on HIV, promoting leadership and mitigating the negative impact of HIV and AIDS in human development, which will run from 2009 to 2011, is being implemented this year. Next slide, please. In the areas of treatment, care, and support, some milestones I want to share with you are the following guidelines, standards, and protocol for reporting, treatment, care, and support. These are the National STI Case Management Guidelines, guidelines on the entry of people with HIV and AIDS to the Philippines, guidelines for AIDS investigation, guidelines on management on HIV infection, home-based and hospital-based care guidelines, and care and support training manual for social workers. Next slide, please. As shown by the HIV data, much is needed to be done still by us as a country. A multi-sectoral response where local response is at the center is highly desired for. Our aspiration is to contain the epidemic and harnessing the gains of the past and applying the knowledge of the present. We look at packaging our intervention that will reach the widest portion of our target groups and empower them to make or to take on behavior change. And lastly, our concern is to sustain the country's procurement of ARV and encourage and build a greater and meaningful engagement of people living with HIV. Maraming salamat po. Thank you.
Salamat po. Thank you. Now I would like to invite Dr. Mario Agustin to present Timor-Leste HIV/AIDS situations and respond. Dr. Agustin? Dr. Agustin, now it's your turn to present Timor-Leste HIV/AIDS situation and response. Hello? Hello, Timor-Leste? it seems that
HIV
we have...
in Timor-Leste. This will be a short presentation.
Okay, please, Doctor.
Okay, it is okay now?
It's okay now. We can hear you loud and
clear.
clear.
Thanks for welcoming me for the presentation. It will be a very short presentation. What will be the course objective? It will be first to know the prevalence of HIV/AIDS epidemic in Timor-Leste, know the impact of the epidemic, and identify challenges and opportunity in terms of HIV/AIDS programming. First of all, let us start with a brief background of the country. Let us say that Timor-Leste is sharing the island of Timor with Western Timor, and it is called Timor-Leste or Timor-Leste, but the official name is Republic Democratic of Timor-Leste. It has been... I would like to ask if you are seeing the PowerPoint presentation. Jakarta, do you see the PowerPoint presentation? Jakarta, are you listening?
We have your slide. We have your slide on the screen, Dr. Agustin.
Yes, we hear you.
Thanks, I can proceed. Okay, thank you. So, like I said, Timor-Leste is the newest nation in the world. It has been independent in 2002. And it is considered one of the least developed countries in Southeast Asia. Let us say that the demographic data from the 2004 census says that we have approximately 1 million persons living in Timor, with a population growth of more than 3.2%. But the fecundity rate is very high. We have more than 7 babies per woman, and the population is quite young. Like I said, the latest data shows that 61% of the persons living in Timor-Leste are below 25. The literacy rate is about 73%, but it depends. If you go higher, the high university knowledge is very low. But the general literacy rate is approximately 73%. In terms of economic data, we can say that Timor-Leste is considered one of the least developed countries, and they live with less than 0.8 cents a day. So it is data that can show you the difficult situation that Timor-Leste is facing. Now, in terms of HIV/AIDS, what we can say? That we can say that in terms of HIV/AIDS, Timor-Leste is still considered a low prevalence country. It means that the prevalence is 0.17 to 0.23%. It means that it is an estimation. And we can say that actually 94 cases in October 2008 have been identified by the Ministry of Health. But we can say that the latest data, for example, published by the Ministry of Health, shows that there is more than 117 persons infected in Timor-Leste. And 30 of them are receiving ARV drugs. The age group of the person infected with HIV, they are between 15 to 39. And the youngest case identified is a young kid, 13 of age. Now, what about the HIV/AIDS response in terms of Timor-Leste? Like I said before, the prevalence of HIV is very low in Timor-Leste, and still it is not considered a high priority by the government. Because Timor-Leste, as I said, is the newest country in the world, and they have other commitments, other priorities. And the existing program is targeting the most at-risk groups, including MSM, men having sex with men, sex workers, uniformed service members. There is no such program for injecting drug users. And there is no direct program targeting the general population. Most of the programs are being implemented by NGOs and through the Ministry of Health. The challenge, like I said, it is the same as everywhere. We have the low use of condom because of culture and religion, because data shows that people still do not use condom because of culture, because of religion. I have to say that the Catholic Church is very present and is very powerful in Timor-Leste, and people, they hide about on their belief when he has when you tell them to use condom. There is also another challenge, the lack of information in vulnerable groups. Like I said, in 2004, a study from FHI shows that only 29% of sex workers were in fact using condom. And in the last study shows that only in the general population, only 15% of the people know about HIV/AIDS. In the health sector, there is a VCT center, but until now they were not very active. But from this year, they have installed more than 15 VCT centers. So that's why they managed to find out in less than this last quarter 13 new cases of HIV/AIDS person living in Timor-Leste. And the PTMC, that the program for the pregnant mother, to prevention of transmission mother to child, is quite not very well. And in terms of challenge also, we can say that the governance of HIV/AIDS program is still, like I said before, Timor-Leste needs to build its capacity in terms of governance, not only governance in terms of HIV/AIDS program, but also in governance in terms of other issues. And the availability of data usually is very challenging. It is very difficult sometimes to obtain clear data related to HIV/AIDS, not only for HIV/AIDS, but also for other topics, other themes that are related to the country. And the last but not the least, the stigma and discrimination factor. Because although there is a drug available in Timor-Leste, although there is a service available in Timor-Leste, but people, by fear of stigma and discrimination, people do not frequent the health center. But what are the good practice in terms of HIV programming? You see, there is a good involvement of the UN system. Like I said, many agencies, UNICEF, WHO, UNESCO, and also UNFPA, they are doing a very good job in terms of supporting the HIV/AIDS response in Timor-Leste. This is one of the reasons that I'm right here presenting on behalf of the Timor-Leste government. The NAC has been created, although Timor-Leste was the last one to sign the UNGAS declaration. So they have managed to create the NAC. But the NAC is still under, as I said before, as Timor-Leste consider HIV/AIDS program as a medical issue. So they put the NAC under the Ministry of Health. So which is a problem, because in many countries they put the NAC higher than that. They put it directly under the presidency or under the prime minister. But in Timor-Leste, the NAC is still under the Ministry of Health. They have the 3-1 principle, like my colleague says a few minutes ago, related to his program. They have agreed to the 3-1 principle. So it means that everyone must follow one national program, and there is one coordinating body, and in terms of evaluation, there is only one evaluation body. And the good point also, there is the presence of Global Fund to support HIV/AIDS program, HIV/AIDS activities. Actually, for population less than 1 million person, the Global Fund is supporting the HIV/AIDS program for at least 9 million US. Like I said before, in conclusion, Timor-Leste is still a low prevalence country, but low prevalence means it's time to establish a good prevention program. Like I said before, in Timor-Leste, they still consider the target group the most at-risk group. But we have seen that in the general population, the knowledge about HIV/AIDS is very low. And like I said every time, Timor-Leste, although it is a low prevalence country, they need to focus on their effort, because they can be transformed in the Venezuela epidemic country in less than 10 years. Because I gave them the example of neighbor countries that were exactly in the same stage 10 years ago, and now they have been transformed to Venezuela's epidemic country. So I said to them every day, Timor-Leste is a low prevalence country, but it is time to establish a good prevention program. Thank you.
Thank you, Dr. Agustin. Now we move to Malaysia. I would like to invite Dr. Karina Rizali, joining us from the University of Sarawak site. Dr. Rizali, please.
Okay, thank you, Mr. Chairperson. Can I have my slide up, please?
Okay, now your slide is on the screen.
Okay, thank you. So I'll talk very briefly about the national level HIV/AIDS impact in Malaysia. Next slide, please. I'll cover a few brief topics basically on the epidemic profile of HIV in Malaysia. We'll talk about populations at higher risk because Malaysia shows a concentrated HIV epidemic. What are the current responses and interventions that are already in place, as well as issues and challenges that we are facing here in Malaysia. Next, please. So Malaysia is a country that is made up of over 27 million population currently, and it is actually divided into two geographical areas. The first on the left is the Peninsula Malaysia, and on the right you see is the East Malaysia, or also known as Borneo Malaysia, where it's there with Kalimantan, Indonesia, and bordering with Brunei as well. It's a multiracial and multi-ethnic, multi-religion country. We've got Malays, Chinese, Indians, as well as indigenous population groups. And the main religions in Malaysia are, officially it's a Muslim country, but we also have a significant proportion of Buddhists, Christians, and Hindus. We border with Thailand, Brunei, and Indonesia, Kalimantan. Okay, next. The first reported case of known HIV in Malaysia was in 1986, and it was actually a case imported from injecting drug use. Sorry?
Hello, Malaysia. You were frozen for a while, so we were
we can off for a while, but now it's okay. We can continue now.
Okay, can you hear me now?
Yes, we can continue, yes.
Okay.
Yes.
So I'll just repeat this slide quickly. The first reported case of HIV in Malaysia was in 1986. And since then, by the end of 2008, we've had a total of more than 80,000 HIV reported cases. Actually, it's about 84,000 reported HIV since 1986. Malaysia is categorized as a concentrated HIV epidemic country, with more than 5% known among a particular high-risk group, which is the injecting drug use. And among the IDUs, it's estimated that it's about 20% prevalence, and about 5% among men who have sex with men, as well among female sex workers. Next slide, please. The way HIV is documented, notified in the country is through passive and active screening, through the Control of Infectious Diseases Act of 1988. HIV is a mandatory notifiable disease among government hospitals. So that's how we get most of our reported cases. All donated bloods are screening. Mothers attending antenatal clinics are also given HIV screening. All TB patients, all patients at STD clinics are also screened. Recently, at the start of the year 2009, there was also a new policy introduced where for Muslims only for now, those who are attending premarital causes will also be given mandatory HIV tests. Among injecting drug use, those who are upon entry to the drug rehabilitation centers and into prisons are also tested for HIV. In addition to all of that, the country has also now initiated a voluntary counseling and testing service, started recently and also expanded throughout the country. Next slide, please. This is the graph showing the number of reported cases over the years since 1986. You can see it peaked at about 2002, but in recent years, the numbers of reported cases are declining. And to be honest with you all, we also can't really find a good explanation for this decline. Is it a real decline in the epidemiology of HIV? Or is there some artifact or reporting system or surveillance system? Or if it's actually an impact of one of our intervention measures, which is harm reduction among IDUs. Harm reduction among IDUs was initiated in 2005 as a pilot test and has been expanded recently to nationwide. Some will say it is too soon to see the impact of harm reductions, especially since the coverage isn't that wide yet. So it's one of our key interesting areas to see how far does this trend continue and what can actually explain it. Next. The three graphs shows estimated numbers of HIV. The estimated adult HIV prevalence for Malaysia was thought to be about 0.5% among adults in the year 2007, and the estimated number of people living with HIV was about 80,000 in 2007, and number of AIDS deaths was about 4,000 in 2007. The thing with these estimates, it's probably an underestimate considering that by the end of 2008, we were already seeing over 80,000 people living with HIV among reported cases alone. And if we all know how HIV is, how it has a strong underreporting component to it through non-clinical symptoms, through underreporting among marginalized and hidden populations. 80,000 will be at the minimum of our estimates. Okay, next. So I mentioned that the injecting drug users remain the key driver of the epidemic. But in recent years, we are seeing an increasing proportion of sexual transmission of HIV in the population, and with it comes an increasing proportion of women among infected. And I mentioned we saw the observed decline in reported cases. One argument about surveillance was because IDU was the initial key population, surveillance among the IDU population is very active through the rehab centers and through IDUs in the prison settings. But with this change in transmission dynamics, it is possible that we are still only focusing predominantly on the IDU population, and that's why we are seeing the trend, the declining trend in reported cases. So perhaps we are missing out in detecting a different subset of the population who are sexually transmitted, and that may explain the decline in reported cases. Next. The three lines is showing the number of cases by risk factors, and this illustrates what I was mentioning just now. The blue line is the decreasing trend in reported cases among IDUs. So of all reported cases, IDUs initially was about 70 to 80% of all reported cases, and now it's only just under 60% or about 55%. The red line is the number of cases reported due to heterosexual transmission, and you can see the increasing trend. The line showing the MSM transmission is also believed to be a severe underreporting because surveillance among the MSM group is very lacking, and also there is not an active presence of the MSM population, so it's very much a hidden population, so we don't know much about the MSM group in Malaysia. Next, please. So this table shows the proportion of females among total reported cases over the years. So we started off with mainly male population, about 90% males in 2000. But in the most recent years, 2007 and 2008, we have increased from 3% up to 16% and now 19% females among reported cases. So that is also a trend that is being on our high red flag, I must say, in terms of how it is starting to spread beyond the injecting drug use population. Next. In terms of regional distribution, with the initial epidemic being among IDUs, the major cities where injecting drug users are more common are the cities where HIV prevalence is highly dominant. And this includes Kuala Lumpur, the capital city, as well as Johor and Pulau Pinang. But in the two states, Sabah and Sarawak, that is in the eastern side of Malaysia, the Borneo, Malaysia, these two show the lowest number of cases overall. But their epidemiology is quite different from the rest from Peninsular Malaysia, where number of IDUs reported is extremely low, and most cases are actually through sexual transmission. Next, please. So if you look at all the different states in Malaysia, this is in order of highest notifiable rates. So basically how many cases notified per 1,000 population, 100,000 population. So the two at the bottommost, Sabah and Sarawak, are from the East Malaysia. They are the lowest reported notification rate. But as I mentioned, they have very different epidemiology through sexual transmission. The middle group, the light blue, the Kuala Lumpur, Kedah, Johor and Penang are the more urban states. And these are where we think IDU and also a mix with heterosexual risk is high. But if you look at the top two most highest notifiable rates out of 100,000 population, the states of Kelantan and Terengganu are the two states at the northern east coast of Malaysia. And they are also the two most conservative and, I must say, rural states. So that is a cause of concern because not much attention has been paid to these two states, and yet they are showing the highest notification rates. The key things about these two states is they are predominantly fishing communities in these two states. And recent data from our needle and syringe exchange program sites there show that among the fishermen, the rate of injecting drug use is actually very high, and with it comes the rate of HIV prevalence. And this is something we need to explore further here in Malaysia. Next. So some numbers for the most at-risk populations. I mentioned IDUs. HIV prevalence is thought to be about 20%. Amongst men who have sex with men, female sex workers and transgender populations, in Malaysia we call them maknya, which is equivalent to the warias in Indonesia. We have very little information about these three groups. Until recently, we don't really have good second-generation surveillance data. So what numbers we have for this are very crude estimates. We think it's about 5% prevalence among these three high-risk and hidden populations. Starting this year, Malaysia is initiating its second-generation surveillance. We are going to do an integrated bio-behavior surveillance among these key hidden populations. So we are looking at HIV prevalence as well as behavioral studies. Next, please. Other vulnerable populations that we need to look at and of concern would be the prison inmates, where again injecting drug use is high among prison inmates. Most of them are actually in prison due to drug-related offences. Among the migrant and mobile populations, as well as refugees and displaced populations, and some of these mobile populations are occupational related, like I mentioned, the fishermen in the East Coast. Youth and women are also vulnerable population, especially looking at the recent trend in the increased number of reported cases among women. And in terms of intervention in Malaysia, one of the key things that has been done in Malaysia is the coverage of antiretroviral treatment. Among the reported cases, those who are at advanced stage of HIV, about 50% are receiving antiretroviral therapy, and the Malaysian government, through the Ministry of Health, provides free treatment for Malaysian nationals for the first two treatment regimes. Therefore, cost for the patient is quite significantly reduced. The issue with the treatment provision, however, is that while the financial and the treatment provision is very good, accessibility is still an issue. So even if we do have provisions for treatment, those who come forward to